Okay, so today my presentation title is linked dimensions of psychopathology and functional connectivity. So it has become really increasingly clear that the clinical labels that we use, from the DSM, don't really carve nature at its joints. Which means that these labels don't really map onto the underlying biology very cleanly. So two examples of this is one is very high level of comorbidity, between diagnoses, right, and a high level of, so the second example is a very high level of heterogeneity that within individual disorders. So as proposed by the NIMH research domain criteria, one potential solution then to this problem is to take a dimensional approach that seeks to capture kind of circular level abnormalities that cut across these diagnostic boundaries. So in addition to this, one another really important observations of psychiatric disorders that more than 75% of all mental illness diagnoses are made before the age of 25. This really underscores the need to study youth as if we were to better understand psychopathology. And this also led to many neuropsychiatric disorders as reconceptualized also as kind of disorders of brain development. So this really emphasizes the need to study how abnormalities in critical brain systems, kind of arise in adolescence to produce these symptoms of mental illness. Actually, indeed, in the past about 10 years or so, network neuroscience kind of really shown us that network modules during development also kind of going through very dramatic changes during development. Now, what are network modules? These are basically kind of these very highly connected brain regions, right? So the specific patterns, for example, that's kind of network neuroscientists have found is that connectivity between these modules tend to increase with age, and network connectivity kind of between two different modules tend to decrease with age. In fact, when we look at kind of adults with psychiatric illnesses, these network modules also show abnormalities in this network configuration. So now this leads to the hypothesis that perhaps during the normal process or deviations from normal process of a brain network reconfiguration might actually underlie the vulnerability of psychopathology. So combining this rationale of network neuroscience and the dimensional approach to psychopathology, the overarching goal of the study then is to delineate linked dimensions of psychopathology and connectivity in brain networks by mapping specific patterns of functional connectivity to psychiatric symptoms across clinical categories in a very, very large population of youth. So we studied 999 participants from the Philadelphia Philadelphia neurodevelopmental cohort who received the fMRI as well as comprehensive psychiatric evaluations. And first, we subdivide this 999 sample into two parts. One is the discovery sample with 663 subsets, and the replication sample with 339 as a replication data set. Now, both these two data sets are matched in terms of age, sex, race, and overall psychopathology. Then we constructed a functional adjacency matrix for basically each of these subjects by applying the Jonathan Powers 264 node system, which comes with the a priori community as the a priori community assignment, which is the network affiliation of each node. Now the goal here then is to find some linear combinations of these functional connectivity that are maximally predictive of some linear combinations of the psychiatric symptoms. And one way to do this is something called a sparse canonical correlation analysis, which is an unsupervised learning technique that seeks to capture sources of common variation that are shared across these two highly dimensional data sets. So let's look at what we found. So based on the covariance explained as well as a permutation testing procedure, we found three statistically significant linked dimensions of connectivity and symptom in our data sets. And I call those linked dimensions because each of these significant canonical variate represents some form of linear combinations of the functional connectivity that are very correlated with some combinations of psychiatric symptoms. And as you can see, these are the scatter plots for those linked dimensions here. But in order to thoroughly understand what's really behind these link dimensions, right? These are significant, but what do they mean? We did a resampling procedure to look at, to identify clinical features in each dimension that are reliably contributing to each dimension kind of across multiple subsets of the data. So here what I'm plotting, showing you on the slides is on the outer ring, these are the specific psychiatric symptoms. So these are, because these represent the clinical features. And the colorful arches, or the arcs that immediately adjacent to that represent the DSM categories that these symptoms belong to. I'm plotting it this way is because we're explicitly interested in how our data-driven dimensions compare to these traditional clinical boundaries. So now let's look at the first dimension. As you can see, the first dimension is mainly composed of psychotic features, such as auditory hallucinations, in addition to a couple manic symptoms as well. But perhaps the second dimension best represents, which we, by the way, term anxious misery, best illustrate how these data-driven data-driven dimension of psychopathology really incorporates very diverse symptoms across categories, right? So here, as you can see, the second dimension incorporates symptoms from the psychosis, the domains from psychosis, depression, mania, suicidality, and OCD. But so most of them make sense, but a couple ones don't really, right? So the mania and the OCD. But if you look at the specific items that are contributing to this dimension, for example, the item from mania contributing to this dimension is actually irritability, right, lower right here. And also the specific item contributing to OCD is actually obsession with the thoughts of hurting others or self. So the third dimension, really quickly, is just a dimension of fear symptoms, and the fourth one is externalizing behavior with ADD symptoms and oppositional defiant symptoms. But hopefully that you can see that by combining these significant features together, by examining them together, you can see that while these data-driven dimensions concur with our current clinical experience or current kind of clinical understanding, there's a very high degree of crosstalks between these kind of traditional categorical domains that that make up these novel dimensions. So having defined what the clinical features look like or what they mean behind each link dimensions, what do the brain side of things look like? So here so what I'm showing you is the summarized. So we also investigated, right, the loadings of the functional connectivity in each link dimensions, and here I'm showing you by summarizing these loadings on the basis of within network connectivity and between network connectivity. So we won't have time to go through kind of each of them, right? But as you can see that there's certainly very complex and distinct patterns of functional connectivity that is highly associated with each new dimension of psychopathology. But one takeaway message I want you guys to walk away with, even though without going into the details, is that, so like I said previously, in the normal process of neurodevelopment, our brain tends to kind of more going into segregation, right? So default mode, for example, likes to, so that there's increased connectivity within default mode, and the frontal, would kind of segregate in the normal process of development. But here in the disease states, in contrast, you can see there's kind of ocean of redness. So those kind of denote the increased connectivity between different networks, right? So there's a loss segregation kind of across the four different psychopathological dimensions. But in addition to these very distinct patterns of functional connectivity, there's also shared connectivity dysfunction that are common to all four new dimensions of psychopathology. So what I did here is to, by examining the overlapping features across these four dimensions, and compared that to a null model and ask what are edges, kind of features are common to all four link dimensions. And here I'm showing you on a nodal basis. And as you can see, regions such as the frontal pole, the superior frontal gyrus, the medial temporal gyrus have marked high loadings onto them across the four psychiatric dimensions. And these, so red means that they are belong to the default mode network, and then if the yellow there means from the frontal parietal network. Since we're blessed with a large kind of population of youth in our data set, we also looked at the developmental effects and sex differences. And we found that indeed there were significant developmental effects in brain connectivity that are highly associated with psychosis and anxious misery dimension. And there are significant sex differences in the fear dimension and the anxious misery dimension, which so both of those two accord with our known differences in non-sex differences in psychopathology. But lastly, probably most importantly, is that we repeated the same procedure in our replication sample to further test the generalizability of our results in the left-out sample that we set out from the very beginning. And as you can see, by applying the same procedure, SCCA reviewed the same 4 dimensions that are highly resemble of the original 4 link dimensions. And all of these 4 are significant by using the same permutation test after FDR correction. So in summary, hopefully I've kind of convinced you that in this, by leveraging a really large data set of neuroimaging in youth and multivariate analysis techniques that we have found in a completely data-driven way for brain-informed psychopathology dimensions that were significant, interpretable, and replicable. So with that, I would really thank my advisors, my advisor Tess Satterthwaite and Danny Bassett, and my colleagues at the University of Pennsylvania. Thank you very much.
Do we have any questions?
Hi, nice work.
Thank you.
Could I ask you, do you do any dimensional reduction before feeding the connectivity metrics into the CCA?
That's a great question. So I definitely experimented with the dimensionality kind of reduction using PCA, for example. But in the final analysis, what we decided on is that because CCA is kind of since it's a unsupervised learning, it's already kind of difficult to interpret the loadings. We wanted to make sure the features are as basically true or raw to its nature as possible. So what I fed into CCA are the original edge strength based on the functional adjacency matrix. But in order to reduce the dimensionality, also, right, I can't possibly feed all the 30,000 features into the CCA because John Power's node has 264 by 264. What I did is that I only fed into the model the top 10% of the edges that have the highest variance across the subjects. The rationale behind that is that, let's say if an edge has a really high kind of strength, but it's really high across all 1,600 or 1,000 subjects, that's not very predictive, right? It's not going to have a high predictive power. So you want a feature that is kind of varies quite a lot across subjects. So that's what we kind of decide on at the end.
A quick one.
Great presentation. To the point about cutting nature at its edges, it seems like cutting nature at its edges ideally would look like a particular brain state matching up with a particular behavior or symptom, rather than a cluster of weighted symptoms. So I'm wondering if you had a chance to conduct analysis on particular symptoms, and if any one given symptom showed significant correlation with one of these networks.
Yeah, so and the answer is no, we didn't look at one specific symptom at a time. And the reason why for that is that kind of across 111 items, right, there are a lot of kind of symptoms are, at least on the kind of on the face value, they are assessing the same thing. So a lot of high collinearity kind of within the data structure. So by applying a multivariate kind of tool, we're able to take care of that problem.